to everybody. Just letting people in from the lobby. So welcome to the National Informal Discussion Group for personalised cancer care in primary care, community and neighbourhoods. And you might notice a slight change to our title. I've just added in neighbourhoods to kind of capture the changing NHS, which we'll be talking about this morning. So my name's Sandra Dyer. I'm a clinical advisor for Wessex Cancer Alliance. And welcome to any new people that are joining us today. So this group really focuses on how we can support people living with beyond cancer in primary care, community and now neighbourhoods. And we meet every 3 months. Please do send this invite on to or tell people about this group if you think that they would be interested and share the content. And it really is an informal meeting. We want people to kind of take part and to and discuss with us. So please use the chat or raise your hands at the end if you'd like to speak. And then finally, we'll be recording, which I'm just going to do now. Okay, it already is recording. That's great. So if you don't want to be on camera, please switch off your camera. But we'll obviously be recording the content, and that's really important for those not able to attend today. So with no further ado, I'm going to hand over to Jane. So Jane Windsor is Director of Nursing and Allied Health Professionals at Wessex Cancer Alliance, and she's going to be talking today about the NHS Cancer Plan. So over to you, Jane.
I'll turn my microphone off. Hello, morning everybody, afternoon now, sorry. So thank you, Sandra. Thanks for asking me to come today. Sandra says my role is in Wessex as the Nurse Director for the Cancer Alliance. And I put together a bit of a slideshow around the 10-year plan, but more specifically what the implications are for primary care in terms of that plan. I'll share my slides, but I'll talk around them, and I'm mindful that I do repeat myself a little bit and I go off at a tangent, so bear with me and interrupt me if needs be. Can you all see those? So essentially, over the last year, really, we had some clinical working groups putting together a new cancer plan. So it's the first cancer plan, really, that's come out for a number of years since, I think, I'll be wrong if I say 2010, but it's been around the last one's been around for many, many years. And really, we've had a couple of iterations of draft plans, but nothing concrete. And we worked in clinical reference groups across the country to formulate and support the development of the plan, which is very much driven from a Department of Health point of view, and in the background of massively shifting sands in terms of the geopolitical landscape that was happening at that time. The important thing about the new cancer plan really is that it's shifting cancer care towards prevention, moving to much more early diagnosis, that's stage shift survival measurement, person-centred care and living with and beyond cancer. So when we were developing the plan as a working group, we had ministerial oversight from who was then West Streeting's junior minister, Ashley Dalton, who herself was living with metastatic breast cancer, and she had a very strong lens on making sure that we included a lot of living with cancer as well as beyond cancer in that plan, and you'll feel that coming through, and what's happened as a consequence of that is primary and community services have become very central in the delivery for a lot of the content of the plan. On top of that, of course, as you'd expect, there's a lot more around self-management, around digital pathways, and then thinking really about cancer much more in terms of it being a long-term condition, which we've always historically been quite resistant to, and resistant to in terms of not being super specialised, and we're very special in terms of cancer, but equally some of the, we're in that, I suppose, as we are with every other long-term condition, really, you've got the super specialised stuff that sits in secondary care and can't be moved out, like radiotherapy, for example. But also there's a lot of work that can very easily happen in terms of thinking about services that are delivered closer to home. And the 3 shifts, as you know, were really clear that we need to move from that sort of sickness to health, analog to digital, and care closer to home. And the foundations really of the cancer plan were about fixing those fundamental pieces of that, and enabling patients. They talk about empowering patients. We tried to change that to enabling in the narrative, but it kept being flipped back to empowering. And then thinking about the future. So there's definitely a 10-year trajectory really of delivering this. So there's some immediate stuff that needs to happen around improving diagnosis, but there's also that long-term transition to much more digitally supported approaches to care. They're shifting the narrative from what was always, we've always talked in terms of the stage shift. We're moving to a survival, a 5-year survival statistic, and also there's a big focus on what happens to people following their cancer treatment. Of course, at the same time, we had all the other documents that were coming out, the elected reform plan, all the stuff that's happening in the background. So in the background, there's been this merging of all the integrated care systems. From an alliance point of view, we've 20 cancer alliances across England that don't follow the same footprint at all as integrated care systems. So in the Midlands, there's one cancer alliance got 6 integrated care systems that it works to. So the complexity of the boundaries and accountability, responsibility processes have become quite tricky to navigate. And at the same time, layered on top of that has been the delegation of specialist commissioning, and a lot of cancer sits in specialist commissioning. And so we're in that transitional period at the moment where some of that's being devolved. And at the same time, also, our role has been much more strengthened in the plan. We've got the work that's happening in the background as well. We're waiting for the nursing midwifery and the workforce strategies, which again are going to strengthen our roles as nurses even more. There's a lot of move towards things like, more consultant nurse roles. There's going to be a lot more about whole system transformation work. So what does that need to look like? If we're moving stuff, we're moving all this stuff. So we're looking at improved cancer performance, we're looking at better quality, we're looking at improved diagnosis, we're thinking about new models of care. And I appreciate Teresa came last time and talked about the neighbourhood model. So I'll try not to repeat that, but it's really relevant in terms of thinking about not just about primary care, but the community and the voluntary sector's contribution to that. And how, for me, there's something about how we knit all of that together to make it more seamless for patients, but equally more usable for people in all of those settings. And therefore, what we want to do is completely get rid of the current fragmentation of care. So as I say, workforce development is a key part of that. And then there's a whole other bit, which I'll talk about in a minute, around rarer cancers. There's a whole chapter on teenagers and young adults. And there's a big juggernaut running through the middle of it all, really, around research. So for primary care, there's a real thread that runs through the whole plan, really, about detecting cancer earlier. There's a big push to make sure that we reduce unwarranted variation. So there's a lot of discussion around excluded populations, people who find access to healthcare difficult. Of course, at the same time as all the digital architecture changing, we're already seeing digital exclusion getting worse at that time that we're having these conversations where we're saying people, we need to make everything more accessible. So we've got this sort of dilemma happening at the moment, that we want to improve personalisation and person-centred care. We want to think about integration of care, and with the NHS app, of course, being the new front door or whatever the expression is. But actually what we need to be really cognizant of is how that impacts on people on the receiving end of care. So whilst we want to do all of that and we embrace, new digital solutions, we want to have more supportive technology. You have to be careful that it's supportive and not replacement technology. And we want some systems in place that make all of our jobs more efficient and effective. What we don't want to do is exclude people further by putting systems in place that they can't use. No, it's not letting me move. So the national commitments which will affect you in terms of primary care really are the changes in the diagnostic standards and expansion of community diagnostics. So the community diagnostic centres have been writ large actually throughout a lot of the plan in terms of using them. Now, some of that is more about having care closer to home. From my point of view, what we see as a slight difficulty really with CDCs are that what's sort of happening is money's being put into community diagnostic centres and they're evolving into sort of an extension of an estate in some places. So actually what they're just doing is having an annex onto a secondary care building at the moment, which isn't really putting care closer to home. We're still not, that process doesn't feel like it's landing as effectively as it could do. And we've had some challenges in rolling out some of the CDC work because some of the commissioning behind that has involved tariffs being attached to new pathways, which of course none of our pathways really are new. So therefore the financial incentive to shift work into community diagnostic centres has been slightly reduced. There's a real intention to improve direct to test pathways. And when they talk about direct to test pathways, they mean things like 111, they mean things like self-referral pathways, and some much more telephone triage, some of the things like the breast lump pathways, whereas do you need to go to a GP if you've got a breast lump for a GP to refer you in, or is it best that you can self-refer and the notification gets sent so that primary care acts cited on that referral, but actually you're not building any delay in the pathway whilst that happens. There is going to be much more around safety netting. Care and support planning is going to be much more out of secondary care, and then
having a rough day. Oh, what's wrong? How are you?
And the other thing really is about better data sharing. So we're going to a shared care record and then we're moving to a single patient record, which is going to be much more beneficial, of course, for all of your services. But you will see an increased use in risk stratified screening. So there is going to be something about things like polygenic risk scoring. So there will be some digital infrastructure that's going to come in that's going to make your whichever IT system you use in your practice to be able to, rapidly escalate patients in your practice that will have will be at increased risk due to their family history, due to any known genetic risk factors. Also things like lifestyle, the things that are going to really raise somebody's risk around lifestyle factors. There's going to be some more direct access to diagnostics and greater use of some decision support tools. So there'll be more digital, inbuilt digital thinking really in your IT systems, and then some more IT support for safety netting, and most of that is to stop people having to track everybody all the time. The systems that we're looking at the moment that we'll be moving towards will be constant, rather than people constantly daily checking to see if a scan's been booked, for example. It'll be booking it, flagging it, telling you when it's done and telling you what the next step needs to be, for example. There's much more push to use things like FIT as a universal triage tool. There are things like ColoFit, which is an even more refined algorithm, which is being validated at the moment, which will give you some different permutations that tell you who are at even higher risk of having colorectal cancer if they've got an elevated FIT, or should they then go off and you would naturally do a calprotectin or whatever, wouldn't you? But in a certain age group. But there's something about standardizing some of that. There's clear guidance coming through for low risk but not no risk symptoms. And so there's going to be much more data-driven approaches to care, and probably much more protocolized in terms of getting some standardization. The net expectations for the plan really strengthen safety netting. So they want some very clear documentation. They want some digital tools to track those results and flag and recall people, but to share that responsibility. So I think one of the things that we feel very strongly from an Alliance point of view is what we don't want to happen is to push work from secondary care onto primary care, because secondary care is bursting at the seams. It has to be, from our point of view, the the intention behind any shift has to be because it's in the best interest of the patient. And if so, then what does the workforce modelling and the capacity need to look like in whichever sector we're asking to think about absorbing some of that work? What does that need to look like? So thinking about the economic analyses that go behind it, what does the workforce modelling look like? And what would the patient experience and things like the inequalities access be on the back of that? There will be, the NHS app will have a self-referral portal. I mean, it's interesting, isn't it? I think one of the things that we miss constantly and we don't talk enough about is about people's self-efficacy. And I think one of the keys for me to all of this will be about really understanding people's ability of self-efficacy. So we know in terms of, and you'll know, in terms of quality of life, health-related quality of life, the outputs are really clearly defined. Doesn't matter what we do to people in secondary care in terms of, radiotherapy, SACT, surgery, every complexity that you could have. The biggest determinants of output for health-related quality of life for patients are self-efficacy, previous histories of anxiety and depression, multimorbidity, and things like social isolation, which you'll know really well. They're the things that you're seeing all of the time with that client group that you see constantly that come in and out of primary care. You've probably known them all for years, and you're probably doing this far better and more effectively than we've ever done in secondary care. So it is important. It is really important that we sort of harness some of your existing talent. I'll talk about that in a minute in terms of some of the late effects work. The introduction of personalised care plans is they talk about introduction of personalised care plans like we've never done it. I think what's never been done well probably is the documentation of that care plan and the sharing of that care plan. So we're, in secondary care, if you're a clinician in secondary care, you would, you'd have a plan with an individual, but it very poorly shared with you in primary care. So when you go to a cancer care review, for example, in primary care, it would be really helpful if you had that plan. So some of the work we're doing in the background is some very structured work around end of treatment summaries that are actually written for patients, not written for coding and GPs. So we're doing some, what would you need as a patient? What do you need to know? And then what would you need to know in terms of primary care? What's important for you if you were reviewing those patients? You're likely to be reviewing them for their other multimorbidity reviews. So what do you need to know that's helpful in this instance? We want to think about that. There is a directive that there are cancer leads in neighbourhoods, although that's not been defined yet. We're having a bit of a tension at the moment that the national team are writing new cancer standards manuals. And there's going to be a core requirement in there that runs through all of the manuals. So they're pretty much pulling together, the GIRFT manuals, the improving outcomes guidance, the Royal College guidance. So you only have one place to go for your overall model of care. And what they're trying to do in that space is put some core requirements in there, one of which is about having a neighbourhood cancer lead. We're trying to push quite hard for that to be a registered healthcare professional, even though we really recognise the value of social prescribers and other ARS roles and other members of the multi-professional teams. There's something about continuity of really expert care that needs to happen across that sort of interrelationship. And we're talking more and more about supportive oncology in a much broader sense. So historically, people have talked about supportive oncology in terms of enhanced supportive care, very much symptom management. A lot of supportive oncology clinics have been raised in secondary care for toxicity management, pain control. They've emerged really out of a palliative care background. What we're trying to do at the moment, and the national supportive oncology guidelines being written at the moment, and the draft guidelines have really expanded that. So when the guidelines come out, they'll be very clear that supportive oncology is about supportive care, is about a biopsychosocial model of care, and general practice is a core partner in that delivery. there's something equally in there about acute oncology, and that recognition of acute symptoms, and toxicity, and well, I'll talk about that in a so there will be some work around the important thing really, I think, is we often see a care plan that's been written by somebody in a dedicated tumour group who really doesn't know the family, hasn't looked after mum, dad, children, in the way that in primary care you have that whole family approach. You understand the dynamics that happen in secondary care. Patients, as we all will go into a clinic room, sit in a clinic room. Sometimes they'll have somebody with them, sometimes they won't. You never really understand the whole wraparound care till you see people out of secondary care, do you? Till you know them, till you go and visit them at home, or you really get to know them over a period of time. So actually the contribution as a primary care team that can be made to that comprehensive assessment of need is vital. Otherwise it becomes a treatment plan, and it doesn't become a care plan, does it? So there is something really about us, as I said earlier, like doing end of treatment summaries that are, that really tell people what to look out for in the future, but equally support families and carers to help support, to look after those individuals, but also recognising there was a massive role for social prescribing and wellbeing support in terms of thinking around life, and not necessarily seeing social prescribing on a continuum of care of nursing. But we spend a lot of time really trying to, I have a huge amount of time and respect for social prescribers, but they bring something very different, I feel, to a nursing continuum. And similarly, we've had a problem with some of the cancer support worker roles in acute services who, can really complement the work that the cancer clinical nurse specialists can do. But landing that's been quite challenging. So everybody will receive a cancer plan. And the other thing I think that's quite important is that those relationships with secondary care. So locally, obviously we've got some really good integrated community outreach models that we've been piloting, where our teams of nurses, so Catherine's on the call, Pam Kay's on the call, who are really heavily involved in those outreach services that really help us to work across. They have that fluidity, so they will see people. They've probably spent about 20% of their time actually in an acute hospital, but they move between community primary care. They bring the voluntary services. They work with all of some really difficult communities who don't always have things like recourse to public funds. They don't necessarily have good access to healthcare. They have homeless healthcare link workers working with them, prison link workers. So there are some models of care that are sort of ready to go, really, that pull all of these things together and work really well with primary care. So the CDCs, as I say, haven't quite landed in the way that you'd sort of imagine they would. You'd sort of imagine them to be a filter, wouldn't you? In a way that, if you think the conversion rate for suspected cancer referrals is, still under 10%, of referrals, you would think that there was a mechanism for going to a CDC, having an test for investigation, and then only referring in those people with a high index of suspicion, so that actually those who get seen quicker by the specialist services. But it hasn't quite landed yet. So hopefully those things are starting to evolve. But the thing that we've got, obviously, in the meantime, in the background, are things like the multi-cancer blood tests emerging. So it's only a matter of time before somebody goes in and has a blood test, and they'll tell you that you've got you've got a really high risk of a particular type of cancer based on blood tests. So we've got all of this happening at the same time. So I think that's probably why a lot of the intention of the cancer plan have landed in a sort of in a bit of a we'll do the short term, medium, and long term piece, because the science that's evolving in the background is evolving at such a pace and scale that you can't set out what cancer care will look like in 10 years' time, because in 10 years' time you'll probably walk into Tesco, sit in a photo booth and have a finger prick test and come out having been scanned. You'll have your diagnosis and you'll walk out of there in a heap and run to primary care to see a practice nurse who you've known all your life to say help. I don't know what any of this means. So actually there's something for us to really think about, what does that mean for people on the receiving end of care. We did think when the cancer plan was being written, our understanding from a clinical reference group was very much that a lot of the prevention work wouldn't be particularly embedded in the cancer plan because it was already covered by the 10-year health plan. But actually some of the, for example, HPV work is very particular to cancer, isn't it? So it's vital. So there's some stuff that we wanted particularly left in there, things like there's some regulation around sunbeds, those sorts of things. There's also a lot of, I can't think about it, the sort of particulate plastics that people are now seeing, in people, in postmortems, there's a lot of, I can't think of the word, but, plastics that don't degrade, sort of particulates of plastic that need to be in there, that are in people's postmortem, and where are they all coming? There's all the stuff around air pollution. There's a lot that's happening that's probably not already necessarily being tackled well. And there's something about us from an alliance point of view. So we have a lot of education and training funds, and it's really important that we think about the needs for primary care around, not just around recognising cancer, in those patients that are sitting in your clinic with something completely unrelated that you think, something's wrong here, something's changed, the way they're walking, the way they're sitting, they're not comfortable, all the little things that you as a nurse will intuitively say something's not right, that gut feeling stuff that you feel. There's something around us supporting any further education and training requirements that you'll need on an ongoing basis. There's stuff absolutely around the short, medium and long-term late effects work. So we've got a big program of work at the moment around thinking about toxicity. So there's the stuff around immediate people on treatment that have experiencing or particularly endocrine, cardiac, gut toxicities. And then there's the medium term, so those patients that have got toxicity and they're still under secondary care follow-up. And then there's this huge, huge tsunami of patients that are coming that are discharged at 5 years from their follow-up in secondary care, and they're developing, rheumatology, cardiac, accelerated vascular degeneration, all the stuff that's going to happen as a late effect of immunotherapy that we know is coming, and it's enormous. So how do we get the skill, capability and the workforce, and what does that downstream modelling look like? And that's something that I think is a really big part of our job, to think about. And some of that will be about links with CNS teams, but most of those patients are going to be discharged and they're going to be landing in your clinics, really. And they're skills you already have because you manage all of those long-term effects anyway. If somebody pitches up in your clinic with a rheumatological condition, you would be used to managing that anyway. So actually, does it matter that it came from their immunotherapy if it's irreversible and it's just almost accelerated aging, I guess? But what we need to be cognizant of are the numbers and the scale of that, and how, with our increasingly aging population and the multimorbid presentations that we have in cancer, how does that interrelate to those conversations you're already having for those other comorbidities, I guess. And we need you to help us with that, of course. So the digital and data stuff's huge. There's going to be massive amounts of speedy technology coming, which will be great. But of course, at the moment, we've got there's a lot of tension going on in the background around digital strategies, around sovereign data platforms. Do we want all of our data leaving going to the EU or going to the States? Where is that cloud based? And there's a lot of discussion at the moment around sovereign data platforms, which is quite interesting. But there's huge potential in terms of digital architecture to develop things more effectively. And people that have really enabled, can access supportive resources online, and a lot of our digitally enabled population expect that. People use IT for everything, don't they? Use apps for a lot of things, but we just need to make sure that we don't forget that not everybody can use an app. And also, there's something really about thinking more about advice and guidance, I think. Sorry, I'm not necessarily looking at my slides at the same time as I'm trying to talk. So there's something around us also thinking about where do primary care fit into decision making, what does advice and guidance look like, and then do we, there is something about why do we keep dragging people up constantly to secondary care buildings that often people pay because the parking's so hideous in a lot of the hospitals. People pay fortune in taxes when actually, are there more opportunities for us as clinicians to pick our laptops up and go and sit in a community setting somewhere or in a PCN and do that follow-up, even if they're still under hospital follow-up technically. There's no reason why they still have to come up to secondary care other than for any tests or investigations that can't be done elsewhere. And also, as you know, there's more and more there are more and more opportunities for telephone-led services, and the other thing we really are mindful of from an alliance point of view really is to think about quality assurance that goes alongside that. So what we need to make sure is that consistency and that standardisation happens for people. So we talk about, devolution of care to smaller organisations, but actually we need to know that, that John Smith around the corner, who's setting up a cancer support hub in an old betting shop in a high street around the corner, has some sort of credentials that we would quality assure that to make sure that people get consistent approaches to care. So we have to be very cautious, I think, about making sure that the care that we're recommending is of a quality that's equitable across the patch. So the plan does talk about neighbourhood cancer teams, and I think the way we sort of thought about it much more is around a sort of two-tiered approach. Around there's the neighbourhood work that would happen, as I say, that still comes under the auspices of secondary care. So it's just that they're doing it in a different locality, in a different geography, and there are those things that don't need to be done in secondary care at all. So you have a huge skill set in primary care around health coaching, physios. I think everyone in the world needs to have their own personal OT. Everything that you have in your team within primary care and the community can cover off a lot of cancer work. There's only a small amount, and I know it feels like it's a huge amount of work that needs to happen in secondary care. It absolutely isn't, but we are exploring more and more ways around things like self-reported PROMs, for example, so that if you're on a 3-year immunotherapy program, you don't need to keep coming out to secondary care every 3 weeks. You can just, fill out your tox screen and push it through. And also, take your next round of tablets, for example. We see a lot of people unnecessarily as well. So those are the two, probably the community-based cancer care delivery and the integrated neighbourhood team approach. So what does that really look like? Psychological care is quite important, or is a very important part, of course, of the biopsychosocial model of supportive oncology. And we're hideously poor on psycho-oncology. And so there is something around, all of our lens that we look at this through is around trauma-informed really approaches to care. What does that look like? What is useful for us to support you to be able to do to recognize? Because the important bit for us is the escalation piece. So we're seeing nationally now more coroner's reports where they're citing, I can't remember what it's called, but I think it's Rule 28, isn't it? Regulation 28, where people who have taken their own life could have, if they had conversations, had that been recognised and been escalated appropriately, that might have been avoided. So actually, how do we make sure that the right people are having the conversations and there are escalation pathways so that people recognise their limits, recognise what they're being paid to do at level 2, level 3, level 4, and then that there is an escalation model in place. So it's much more of a rounded approach to care using, it's not putting in whole new systems of care. It's about using the resources that we've got in a much more strategic way and much more appropriate way, and then thinking at a system level, what does system transformation look like? So at a local level, for example, we have data. This is our this is just a snapshot of some of our patients who will have 3 or more long-term conditions. And as Sandra and I, we've talked a lot, haven't we, about what we talk. Frailty is quite a difficult concept, isn't it? And we get a lot of pushback around talking about frailty, but it is for us about physical vulnerability. Clinical frailty is a real thing, and actually, we're increasingly treating people more and more and pushing them from a pre-frail space into a frail space without having that informed shared decision-making conversation with them. So we need to think more sensitively really about how we make treatment decisions, and then integrate with our community teams and our primary care teams to support those people. We're really bad at enhanced supportive care, not best supportive care in cancer, in terms of giving that as a viable option. Sometimes in clinic, clinicians really push often to treat people, and despite the fact we're constantly being lambasted for undertreating people in terms of our age demographic, what we can do if we're not careful is overtreat people and make them sicker. So it's always going to be a fine balance. Inequalities, as I say, a huge thing. So we do need to really be mindful of what we, so Wessex, we are Hampshire, Dorset, the Isle of Wight. We've got an island population. We've got a huge rural population. We've got a coastal population. We've got massive inner city populations. We've got pretty much whole gamut. So how do we then make sure that we don't have one blob blanket approach to the whole region? How do we actually make sure that we lead some targeted outreach work? And of course, that again comes really with working really closely with our PCNs to make sure that those people who don't access healthcare far better than secondary care do. Digital transformation we've talked about. Again, genomics is a massive program of work that's heading all of our ways, and there's a lot of work happening in the genomic space. The other thing that's coming hugely are some of the replacement diagnostics, so things like saliva testing, self-sampling, things that those people aren't going to hit secondary care for a long time. So how do we help you support those patients in primary care before they hit secondary care? So there is something around embedding those risk tools. Some of this will be imposed on us all, but there is something around us thinking about engaging with the personalised care agenda in particular moving forward, thinking about system transformation work. I think it's the key to it all. If you think at a system level, and I know it's easy for me to say because that is my job, so it makes life a lot easier, but there is something around us having that oversight of where people are seen, by whom and when, and thinking about ways that actually would serve that population need better. There will be a need to develop some more cancer focused roles, particularly the coordination roles, but also, increasing the cancer expertise in practices, thinking about screening, thinking about prevention, and possibly having more community outreach teams, which we're batting for quite heavily here to come and work with you all. But it does mean there's going to be more of a workload, more data-driven responsibilities, and closer integration with our voluntary sectors and our community services. And that shift really to a continuous thinking around care and outreach, and not thinking that secondary care is the place that cancer care happens, I guess is my thinking. We're working quite closely with the ICB, all of our ICBs, to think about what this looks like across the patch, to think about that system work, to monitor treatment variations, think about outcomes, but also work with our clinical team. So we have clinical advisory groups for all of our tumour groups who really embed our work in reality, which is really important. And we have 9 GPs working with us who work across our whole geography, but equally they have a clinical advisory group that really, what we don't want to be doing is having ideas over here that have no utility or no usefulness for you working in your day-to-day services. So actually we need people to ground us in that. there will be faster access to diagnostics. There will be stronger partnerships with cancer specialists. We want patients to have better experience. We'll keep monitoring that all the time, but also families. So, there are things like surrogate markers for good care, like returning to work, for example, that we can measure things in a different way in terms of the utility of the work that we do, and also making jobs attractive. We want nurses to stay. So part of my role particularly is to for our nurses across the patch to feel valued, to be recognised for the contribution that they bring, to know that the work they do is vital, and that we'd be absolutely stuffed without you. And so what do we need to do to encourage you to stay and not run for the hills because the pressures of work are becoming so unbearably difficult for you all? So without that additional capacity, it will become more difficult. We do need that variation. There will be some variation in digital maturity, and there will be workforce shortages. So we're planning for that now. We're thinking in terms of our 5-year clinical strategy, what's that going to look like? What do we need to think about? And try and think about equity across our practices. This slide really was just about the principles that treatment will fit around people's lives. There are some real choices and some control, and that there are some modern service frameworks that are coming. The neighbourhood teams there are 2 big camps really with neighbourhood stuff at the moment. One is there's a skepticism at one end of the continuum. There's a lot of skepticism, and we've done it all before, and it didn't work then, and it won't work now, and and the other embracing it in terms of people who can absolutely see the opportunity to deliver care closer to home. They're doing it. We've got some amazing pilots that are doing it really effectively. The reduction in health service utilisation when people have good wraparound support, as you would imagine, absolutely plummets. When our community outreach teams pick up our referrals, the primary care service utilisation dramatically reduces. Those people that you see coming in with fear of recurrence all of the time can be really well supported not to do that, not to keep accessing services because they're terrified, of course, most of the time. So actually, what does that really look like when you think about it? What the problem we have at the moment is we have secondary care saying, I'm not investing in an outreach service because it doesn't benefit us, even though it does. We know it reduces ED attendance, reduces length of stay, it reduces proactive discharge, and that early facilitated discharge is much more effective. But actually, when we have but actually there are really tangible benefits for primary care. So secondary care will say, oh no. Whereas actually for us, we can work at a system and say the benefits happen everywhere. We just need them to invest in that. So in the cancer plan, there are specific actions which are around personalised care and support, supportive oncology, prehabilitation and rehabilitation. A lot of prehab and rehab doesn't need to happen in secondary care. It's probably about 5% of super specialised stuff that you want somebody in a clinical physiology setting to do. The rest of it can happen. We've got work emerging with football clubs, in community gyms, with walking groups. We've got loads of stuff that we just needs to be corralled in a way that it populates a prehab plan for people that is closer to where they live. We need to think about some things like community pharmacy. We can't forget pharmacy is a massive problem for us, particularly oncology pharmacy, because they're really under-resourced and tightly bound by their ability to deliver things like we want to do more self-administration, we want to do more bloods closer to home, but some of the difficulties around tariffs attached to who does those create massive boundaries for us. The other 2 things I want to just touch on briefly, I'll try not to be too long.
Jane, can I just jump in for 1 second, to say we're just probably starting to run out of time. I was wondering if it's worth a pause at this point to see if there's any questions, or whether you want to whiz through the last of your slides.
No, the bits were just about children and young people, but you can read all those because there's some in relation to primary care. The other bits were about regional specialisation and also research and access to clinical trials. Sorry.
Thank you. Sorry to interrupt. Are you happy to share your slides afterwards so people have all that content?
Yeah.
Brilliant. Thank you. Thank you. So just in view of time, I thought it'd be good to open up to any questions for Jane or any reflections on the cancer plan, but also people to kind of share what's happening in their areas. So who would like to go first? Ellie, I can see you've got your hand up. Do you want to go for it?
Hi, thank you, Sandra. Thanks, Jane. That was a really, really interesting presentation. I wanted to ask a little bit about you talked about having a named neighbourhood support person, which I think would be fantastic. I work in Lincolnshire, and we've found that a primary care role of a community cancer care coordinator has been a really, really useful role. They're not registered health professionals, but they do provide that kind of wraparound. You know, they understand the needs of the patient. And what we do to ensure escalation of any issues is we, you know, make sure those protocols are in. So, for example, psychosocial, all our acute and primary care coordinators are trained in level 2 brief interventions to recognise distress and understand how to kind of deal with that in conversations and put brief interventions in for people, but also about how to refer them appropriately. And we have level 4, county-wide level 4 psychosocial services for people who need a clinical psychologist support. So we tend to go that way rather than them needing to be a registered health professional. Do you think that's something that may be more achievable across the piece? I'm just thinking of the workload that primary care have already got in terms of their registered professionals.
I think it's really problematic. I think across all sectors it's problematic. I think there is something about splitting the workload by need, isn't there? So I think our social prescribers, our care coordinators have got a huge role, and a really, really valuable role. So we've got some amazing primary care coordinators across our patch, and we couldn't do without them. And they have my nervousness sometimes, I guess, is about the skill and expertise to escalate. And I think we've got some amazing examples of people that are really safe in their practice and they escalate really appropriately. I think what we need to make sure is the support is there for them to recognise that, because I think I'm not, you know, I think, you know, we pay them quite a low salary, don't we, to do a job that's quite vital.
And it worries, yeah, and
it always worries me.
Yes, and I think, I see your point. So I'm not sure I'm thinking about social prescribers because they have to be generalists.
Yeah.
Really, I'm thinking more about people that are kind of cancer dedicated. But it's really good to hear your thoughts on it. Thank you. It's really helpful.
Okay. No worries.
Anyone else like to come in at this point? Maybe while people are collecting their thoughts together, I had a question or kind of reflection as well for you, Jane. It was really about this kind of left shift to community in terms of whether you think that involves a financial shift or resource shift, because I can't see how we're going to do a lot of this work without it.
I don't think, and I think that's always going to be the different. In fact, you feel like there might be almost a dilution of resource, don't you? Because you know, there's work going into neighbourhoods and work that would historically have been ring fenced for healthcare going into social care. And I don't think, I'm not sure the solutions are there. So what we want to do is some workforce modelling about if these are the models of care that we're thinking about in the future for late effects and you know, good reviews in primary care, what does that workforce need to look like, and what does that resource need to be? Because otherwise we're never going to get it, are we? It will become a race to the bottom, and the level of service that people will experience will be far inferior, won't it, to that which, if it was properly modelled, would be. And I do think there's something around, I know there was a whole cottage industry really around peer review historically, but I think there is an intention not to go back to that. But the quality assurance structure will really support that. So if we can start escalating risk around not being able to provide services in a much more structured way, it will really support our business cases moving forward, won't it, for more staff?
Thanks.
I think I'm just going back a little bit to Ellie's point. So on our call here, and she won't thank me for this, is Catherine Scott-McClay. Are you still there, Catherine? Who I noticed popped in at the beginning. Now, Catherine's a care coordinator for our community outreach oncology service in central Southampton. And I'm just going back to your point a little bit, Ellie, that service would not function without Catherine. Would not function without Catherine. Catherine does the initial phone call. She takes loads of information and what's the word? Does a screening conversation with those people, and is constantly supporting their. Hello, Catherine. Hiya. Constantly supporting them. I don't want you to think I don't at all value that role. I think Catherine's got a vital, and Catherine's really, the other thing Catherine does constantly is say to the rest of the team, you need to ring this patient. You need to ring this patient. Yeah.
and no, I wasn't thinking that you were underestimating the value of that workforce. Yeah. I think I was more, I think the bit that got me thinking was more around, because you were describing kind of primary care as quite a cohesive sort of model where people would have known people for a long time, they would understand the family, and I think that is fairly rare now in primary care.
Is it? Okay.
I think so. I think that things are quite different. So then that one team member who has got eyes on becomes really, really important, because we often get patients who get lost between secondary and primary care, and it's just about making sure that they're safety netted. Thank you.
Thanks, Ellie. I can see, Pam, you've got your hands up, but I wonder if Catherine wanted to add anything, because you came on camera and you went off again. So did you want to add anything, Catherine, to what we talked about? If you're still there. You're on mute.
Yeah, there's nothing to add for me. It's just, I think Jane says it all, and we just provide that amazing service for our patients. That
Thank you.
We can do that.
Sorry, look, I'll turn my camera back off.
Thank you. So Pam, did you want to say something?
I'm just really excited by all of this, really. I was just wondering if you are thinking of doing a pilot of maybe a CNS coming and sitting out in the community. Can you please use us as a pilot, please? We'd be very welcoming. I do wonder in primary care whether we sit very comfortable in our roles, and maybe this gives us a time to actually think outside of those a little bit, and that might not necessarily mean a lot of money that needs to be inputted. I think we can start by looking how we all work together as a team, and maybe changing that. I mean, my role as a practice nurse in cancer care came about by other people in the team sort of shifting their roles as well to enable me to be able to concentrate on that. Maybe we're missing a bit of a thing there in primary care.
I think there's a bit of a call to arms from my point of view at the moment as well, nationally, around nursing, really strongly, that actually I increasingly spend a lot of time listening to people who don't understand how capable and competent nurses are. We have a lot of people still that think that healthcare happens through medicine and management, and I spend a lot of my time saying we don't puff up pillows anymore. We're actually really skilled professionals in our own right, and actually most people don't see a medic till they need a surgeon, or they need their first radiotherapy, and often that planning's not necessarily always done now by a clinic. So you just think nurses do everything, well, and AHPs, to be fair, do everything, and I think that there's a strange perception out there of how much, or how lack of recognition sometimes. So I think part of my call to arms is to really recognise the skill set that you all have. You know, it may not be just be cancer specific, but the breadth and the depth of the knowledge that you have is so transferable to cancer. You know, it's the physiology isn't rocket science, is it? So therefore the consequences aren't rocket science. So, and you've got that expertise in so many other long-term conditions that, you know, you would hit the ground running to do a lot of the cancer work. It's just like Sandra says about the workforce modelling and making sure you're not overburdened with them.
There's a question in the chat, Jane, about reporting from Amanda Watson saying how will you capture personalised cancer care within community and primary care, HNAs, CSPs undertaken in hospital won't be able to be reportable.
Yes, it's interesting.
Out of hospital, rather, sorry. Yeah.
We had this conversation. I can't remember her name. I keep meaning to go back to her and find her. When we did all the digital strategy development work with Maria Hearn, and the woman who's responsible for COSD was there. And I said to her, if we want all this work to be visible, it needs to be visible across every system, doesn't it? And she said it absolutely is possible. It just, and I'll find who she is. I'll go back to Marie, or maybe you'd be able to see her, Amanda. Because she said it's absolutely possible. It's not a problem. It's just that at the moment all the COSD stuff doesn't come out of. It's purely Somerset, isn't it?
Yeah, well, that's interesting because the conversations I've had have been very much it's unlikely to happen because COSD is only secondary care data. But it's good to know that people are starting to think about it, and that's been my concern.
Yeah.
Is you're talking, you know, about the wonderful work that's happening across neighbourhood, and we won't be able to see it if we can't capture it. And I just want to make sure that, you know, we understand the skill sets needed for personalised care, and that we can pull that data in and be able to accurately say this is the group that's supporting patients as we move forward. So yeah. Okay, I'll keep pushing from my side. Marie's going to be off for a while, so I will. I'm slowly doing it my side. But if you come across anything again, please loop me in because I'm really keen to make sure.
I'll go back to the original circulation. I can visualise woman.
Yeah. Okay. Perfect.
I'll find her. Let me know, Amanda.
Thank you.
Okay, so I'm just mindful of the time and not wanting to run over. So Jane, if you get an update on that, I can let the group know of any sort of further information. And want to thank you for your time today coming to speak. And I've just got one more slide to show, just so I can share what's happening at the next couple of meetings for people for information. Here we are. So September, we will have something on research around estrogen blockers and adherence in breast cancer, and also possibly some work around lymphedema from London. And in December, we'll have a longer session, or longer as in the whole session, looking at a quality improvement project around cancer care review in North East London, which is a really interesting project that kind of looks at in health inequities and health equity. So looking forward to that one. So thanks everyone for attending, and we'll share the slides and we'll share the link to the recording once it's available. So thanks all for attending and for your contributions, and look forward to see you again in September.
Thank you very much.